I think that recording means to make a start. Welcome everyone to this evening's session, which will focus on how wastewater can be used as a means for monitoring and improving One Health. I'm your host for the session today, and I'm joined by two brilliant speakers, Professor Davy Jones from Bangor University and Professor Barbara Kasperczyk-Hordern from the University of Bath. Two experts in their own right in the fields of biological and chemical monitoring of wastewater, respectively. In terms of what we've got in store for the session, I'm going to provide a brief introduction and overview of the topic. Then we're going to have two talks. So first up, Davy will be talking about wastewater based epidemiology, its use during the pandemic and its potential beyond COVID-19. And then Barbara is going to be talking about chemical profiling of wastewater for public health protection. Hopefully, we'll save 10 or 15 minutes or so at the end of the session for questions and answers. So please do post any questions into the meeting chat as we go along, and hopefully our moderator, Emma, will make sure that we answer as many of them as possible in the Q&A. So first, a very brief introduction to myself and Arup. I'm a senior consultant in Arup's water business. We are a multinational professional services firm with around 18,000 staff working on projects all over the world. We were founded around 70 years ago by this guy, philosopher and engineer, Ove Arup, and we're owned in trust, which essentially allows us to invest our profits back into things that we think are important in today's society. Including the topic that we'll be talking about today, which is One Health. And more specifically, how wastewater monitoring, wastewater surveillance, or wastewater-based epidemiology, which are often terms used interchangeably, can be used as an effective way of monitoring and thereby improving One Health. So the concept of One Health is one that has been endorsed by the World Health Organization, the World Organization for Animal Health, and the United Nations Environment Programme, and it's gaining increasing traction in literature and key directives around the world. So what exactly is it? One Health is a collaborative, interdisciplinary approach to addressing health issues in a way that recognises the interconnected health of humans, animals, and the environments in which we live, which are all inextricably linked and should be considered together rather than in isolation. This acknowledges that things like diseases can spread between humans and animals, and that environmental factors can play a significant role in the emergence and transmission of things like COVID-19. One Health is an understandably broad topic with many components, water pollution and climate change, which I'm sure you've heard lots about this week, being just a couple of them, and some of which we'll hear more today and more about today in the talks. Many of these issues, of course, like the intersection between different domains where animal health or environmental health directly impacts on human health and vice versa. To improve anything, we must first measure it, and the same principle applies to One Health. There is now an increasing amount of evidence and scientific literature that shows wastewater monitoring can provide a non-invasive and population-wide approach to gathering data about various aspects of One Health. And there is a vast range of things that we now know can be reliably detected in wastewater, which can tell us a huge amount about many aspects of One Health, from pollution and disease prevalence to information about diets and drug use within communities, cities, and entire countries. And this really provides the context for today's session. At Arup, in collaboration with our partners actually on the call today, we've been looking at the future of wastewater-based epidemiology, how it can be applied, and how it can help to deliver in key policy areas. And if you'd like to know more about any of this, then please do drop us a line at wbarup.com. So that is the warm-up act. Now for the main event. First up, we have Professor Davy Jones, who holds a professorial chair in soil and environmental science at Bangor University, A major focus of Davy's research is on understanding human pathogen behaviour in water, food, soil, plant microbial systems. He has recently been co-leading the Wastewater-Based Public Health Monitoring Programme in Wales, and his lab focuses on the detection of biological markers in wastewater. So without further ado, over to you, Davy.
Okay. Thanks, Tom. Thanks for the lengthy introduction. I'm not sure I deserve that, but there we go. I'm based half between Bangor University in the UK and half between Murdoch University in Australia. My work in the UK has largely been focused around public health in the last few years, and we've been leading what's called the Wastewater Based Epidemiology Programme for Wales. What I'm going to talk about today is COVID-19 monitoring, and then what we've done post that. We actually got into this from the One Health agenda, for monitoring viruses and viral flow from wastewater treatment plants into coastal waters, and people getting sick from exposure to hepatitis and norovirus and things like that. And it was a logical extension for us to take that work and not look downstream, but also to look upstream. So in March 2020, or prior to that, we noticed that the COVID pandemic, or COVID Wuhan was kicking off. And right at that time, then we decided that we would start monitoring wastewater for viruses, because we already knew that this coronavirus, would be released in fecal material. So as soon as it entered the country, literally the first flight of people coming in from Wuhan, we were monitoring. So this is a story of where we've been and where we're going to. So Tom, next slide, please. Thanks. So I just want to say thanks to the team. Normally I leave this to the end, but I'm going to start with it. This would not have happened without this team. There's about 20 people here based at Bangor in the wastewater lab, a range of skills from virologists, environmental bacteriologists, etc. So just thanks to them, and thanks to the partner organisations, Welsh Water, who there's only one main water company in Wales, which has really helped us. Arups, obviously, London Data Company, Havern Dyfrdwy, which is the other smaller water company, and Cardiff University. Next slide, Tom. But there's also a range of other partners here who've all contributed to that journey in terms of wastewater monitoring and analysing all of the multitude of sins that wastewater tells us. In terms of the programme, people think of England and UK, but sometimes they don't think about Wales and Scotland and Northern Ireland. We're devolved countries, Wales and Northern Ireland and Scotland, and we have our own government, and we act and monitor things independently from UK government, in a sense. And health is one of the devolved responsibilities for Wales. So we have, we just monitored in Wales. We also worked in Scotland and England for a while, but we're mainly responsible for the Welsh monitoring programme. So next one, Tom. So this is just a little bit of an overview of the monitoring programme. I think there's you might as well click it on, Tom. I think there's another one, I think. So, so in Wales, to do wastewater-based epidemiology, we have 47 municipal wastewater treatment works spread across the country. Each of those green dots is one of them. It's a pretty small country in the sense that it runs from about 350 kilometres north to south, and it's got a population of 2.4 million. 3 million, of which we monitor 2.4 million, 75% of the population using these 47 sites. We monitor wastewater influent 5 days a week using composite autosamplers, and then those are all shipped to the central processing lab in the north, where all of the primary processing is done, and then any secondary processing or analysis, either for illicits, pharmaceuticals and things, either goes to the AMR sequencing lab in Cardiff or to Barbara's lab in Bath, which is just over the border. In contrast to many of the wastewater-based epidemiology programs, our program is based on geography, not on population density, although that is a factor. And we cover sites that have a population of 600,000 people in Cardiff, the capital, right through to small villages almost with 419 people, so really small populations. And that's one of the beauties of Wales, is that it's got a very diverse population density. We monitor for COVID-19 and then a range of other viruses, including influenza, norovirus, RSV, enterovirus, polio, and antibiotic resistance genes. And then through work with Barbara, we've expanded into other things like pharmaceuticals and cultural AMR and protozoal pathogens, etc. we only address policy relevant questions. So because we're paid for by Welsh Government, the only things we can basically evaluate are things that are actually going to influence policy. So we always need to be justifying our existence. And we've been running since March 2020, but the main program's been running for 2 years. Okay, next one, Tom. So this is just oh, back one. I think it's back one. Oh, no, that's no, sorry, back one.
This one.
Yeah, that one, yeah.
Sorry, I think I skipped.
Yeah. So we have a range of different sampling approaches. Mainly, we use composite refrigerated autosamplers at the wastewater treatment plants. There's from 2 companies, Hack and Aquacel, the top 2. But we also lift manhole covers where we've got outbreaks in individual towns and cities, and we want to map to a community or small bits of urban population. Then we've lifted manhole covers and taken samples to see where to target vaccination programs and things like that. We also have sampled open sewers, which is the top right-hand corner. And then in the bottom row, we do hospitals. So we've been sampling composite autosamplers, refrigerated autosamplers outside hospitals, monitoring hospital wastewater, also outside prisons, outside halls of residence, which is one of our technicians in his full PPE suit. And then where we can't do those, we take grab samples. And then the last one in the bottom right is measuring samples in the environment. So the program expands influent wastewater, effluent wastewater, and then we also take samples in the environment at selected locations to look at the One Health agenda. Okay, next one. So we have 4 main work streams that we use, and this is just an illustration. So P1 at the top there, the blue work stream, we take the wastewater samples in, we process them in the lab, we monitor a range of, I guess, classic markers, pH, electrical conductivity, phosphate and ammonium and turbidity, and we use those to normalize for flow. In fact, we have flow data from the wastewater treatment plants almost in real time for our needs. But sometimes where we have storms and the storm water overflows are going off and the flow meters have topped out, we can then use the physiochemical markers to normalize. So using both approaches, we have a sort of a Bayesian model to calculate dilution from rainfall and things to allow us to normalize all the data. So P2 is the viral work stream where we centrifuge the sample, take off the solids, which goes to P3. For P2, we then take the supernatant, precipitate all the viruses, and then extract those and then monitor them using quantitative PCR or via sequencing. And then the pellet out of the centrifugation goes down the channel of P3, which allows us to basically do AMR sequencing, bacterial isolation for antimicrobial resistance organisms that are coming out of hospitals, etc. To see, not only are the genes present, but also do they pose a risk in the sense that they're culturable still, and they're still alive. And then P4, which Barbara will talk about, is more about the analysis of antibiotics and things like that. So, okay, next one. So this is just a snapshot of the sort of work that we do. I think most people have probably seen these in their own host countries now. They're reporting of using wastewater to analyze COVID-19, levels of COVID-19 in the community. But we produce a report every 2 weeks, which goes to Welsh Government, and a snapshot is shown in the little inset there. And then it has a map of Wales. And at the time of reporting here, the time the snapshot was taken, COVID-19 was really low in the population in the summer. It's now on the rise, of course, but this just shows you the sort of data that we produce. And next, Tom. And then this is classically how it maps onto clinical surveillance. So in Wales, we have 2 programs, one which is monitoring COVID-19 via wastewater, and the other one is random person testing. So random person testing is where people take swabs and send them into a centralized lab where they're analyzed, and that picks up about 1% of the population, and wastewater picks up 75% of the population. You can see they track each other really well. Ours, though, the benefit of wastewater is that we are a fraction of the cost of running COVID infection survey. So in terms of cost effectiveness, we win hands down. And of course, there's no ethics and there's no problems with, getting samples from all over the country. We only take 47, they're taking thousands. You can see when the COVID infection survey ends, wastewater is carried on. COVID infection survey has now been cancelled for cost-saving reasons. Yeah, next one, Tom. I think it was that one, yeah. So what have we used the data for? The use case scenarios is really the gold cup that we're looking for. In this case, the wastewater data was used as evidence to prevent us not going into lockdowns in 2 Christmas periods. So the economic savings from not going into lockdowns at Christmas was huge. So I think we justified our existence many times over during those periods and made everybody have a nice Christmas. So if nothing else, it was an extra present. So that next one, Tom. We've been tracking variants in wastewater for SARS-CoV-2. Each of those coloured lines represents a different COVID variant. I think sometimes we forget how that the thing is evolving all the time. You can see wave after wave after wave. It starts with Delta, and you can see in the last ones it's EG5, which is the new one that's on the scene and taking over, the blue one at the bottom. So about every month we get a new variant coming in and taking over, and each of those new variants is much more transmissible than the last one, which means why it's taking over. But at the moment they're getting it's getting less problematic in terms of putting people in hospital. So that's a good thing, but just keeping an eye and watching brief on variants. Again, I think there should be another one, Tom. We generally, with wastewater, with the turnaround time of 24 hours, we are currently running about 1 week or 2 weeks ahead of clinical surveillance. So it always gives an advance warning. And we've mapped it against clinical data, and it's pretty reliable. So, okay, next one, Tom. So where are we going now? In terms of the wastewater portfolio in Wales, next one. So because we get the samples in and we were already set up to monitor other viruses, we've been running other viruses of public health concern. So we've got norovirus G1 at the top and norovirus G2, the 2 different genotypes. Interestingly, they don't map onto clinical surveillance, particularly with G1, which suggests that there's a huge asymptomatic reservoir of norovirus G1 circulating in the population, which we weren't aware of previously. And that's been backed up by environmental surveillance in mussels, ironically, as biosurveillance. And then we've done enterovirus, flu, polio, and RSV. And so we take the 47 sites, take the average, which is the solid line, and then we produce each of these for the individual sites. So here's the 47 sites for flu. There's a pretty consistent picture of a big peak in flu in the winter period, which suggests that actually maybe you only need to take 1 or 2 general surveillance sites for flu, which will give you a good national picture. So in theory, you could scale back the programme for flu monitoring. Not much flu B in circulation in Wales, only certainly flu A. But in terms of norovirus, which is probably a much more good test case scenario, the current testing for norovirus is very poor outside of wastewater surveillance, but you can see that it's much more geographically lots more geographical variation in different places, which suggests that this is more useful on a local level. Next one, Tom. And then we've been using that to look at norovirus outbreaks in hospitals. So we've got 9 hospitals in Wales, which covers about 40 to 50% of the patient beds in Wales. So we've gone for the big hospitals. And next slide, Tom. One of the big issues we have is norovirus outbreaks in hospitals, which causes ward closures. Every year, we have norovirus outbreaks in the hospitals, which cause wards to close, which then prevent people being treated. Obviously, it's not good for the patients, and it prevents operations, and it slows everything down, and it means that it's much more costly to run the hospital than it would be normally. And one of the bits of evidence that's currently available says that if you can, detect norovirus early entry into a hospital, then you have much greater chance of shutting down the infections. So big cost savings. Next one, Tom. And so here's the data from the community wastewater treatment plant and from hospital wastewater. And what we're trying to show here is that you can pick up norovirus circulating in the community much way ahead of it appearing in a hospital. So in theory, if you knew it was circulating in the population, you would have much better infection control within the hospital to prevent the outbreaks. And these graphs are not very well drawn. I apologize for that. But the light blue line for norovirus G1 and G2, the scaling's a bit off, means that basically you can see norovirus circulating in the community about a month before the ward closures and the hospital outbreaks, which would give us a really good advanced warning system. And this now needs critically testing. Okay, so there's some different ways of which you can, monitor norovirus and other diseases circulating in the population. I think there's a animation here, Tom, or something comes in. And of the different approaches, urban wastewater surveillance or hospital wastewater surveillance, I mean, I would say this because I'm a WB person, but it's definitely the most cost-effective and probably best value for money in terms of what you get in terms of data accuracy, the types of sample sizes that you're getting, regional accuracy and response time. And underneath it, you can see clinical testing, which obviously has a huge, very high data accuracy, but is only analyzing a few people, is good regionally. But the response time through the clinical labs is very slow and it's very costly. And yet you've got these other infravalence approaches like internet searching, people searching for Imodium, D&V, diarrhea and vomiting, self-reporting apps, GP surgery visits, etc., people buying medications from chemists, etc. The thing is, what we're not advocating is that wastewater is the answer. What we're advocating really here is that we bring all of these infravalence approaches together to give us the best solution to try and protect public health. So it's part of a combination of approaches, I think, here. Okay, next one, Tom. So just the last bit really is that we've been using the pellets to look for antimicrobial resistance, genes, organisms, and antibiotics via Barbara. And this is to basically help with the national strategy to try and reduce the amount of antimicrobial prescriptions and to see where we could be having better control. Okay, next one, Tom. Next. So we've been using two approaches. One is to use metagenomics and the other one is to look at high throughput qPCR for a whole range of antimicrobial resistance genes, which is down the Y side, the Y axis. And then across the top is different days of hospital monitoring. So monitoring the wastewater effluent out of a hospital. It's the same at the wastewater treatment plant. Generally, the metagenomics gives you a better coverage of all the antimicrobial resistance genes that are there. But the resistomap, high throughput qPCR, gives you a slightly better quantification and really low abundance target that it's better for. But both of them give you pretty much the same picture. What can AMR surveillance do? We're at the start of this journey now, I think. Now we've got these big data sets in. I've only presented a fraction of it. We can see which organisms are involved from the metagenomics by putting the metagenome assembled genomes together. We can see which organisms have those genes in them. Better understanding of how AMR is moving between hospitals. There's anecdotal evidence that it moves south to north and then north to south in the country, but we just don't know. And how many of these genes are actually in organisms, antimicrobial resistant organisms, that are circulating in the natural community, in the general population, and are being introduced into hospitals. So we can estimate all of those. And the idea is that if we can analyze things in a timely way, we may be able to do better interventions for the hospitals. But there's still need to do work with the clinical infection teams to see how they would use that data. And so there's a social science piece of work that needs to be done there too. And then lastly, we've been using it to look at environmental exposure in terms of wastewater discharges to the environment. Okay, next one. So just to wrap up really, the National Wastewater Based Epidemiology Programme in Wales has been running for about 2 years now. It's been highly successful in the sense that it's been able to influence policy, not just do research and produce interesting data. Certainly that's been the case for COVID-19, and we're just at the stage really where the other data streams for norovirus and AMR and things are starting to reap rewards. Wales it's been good because we only have one water company, that's the one main water company, and one government, Welsh Government, who have been really supportive in promoting this. I think it's an unlimited smorgasbord of things that we can analyze in wastewater that will tell us huge amounts of things about the behavior of the population. We've concentrated on the sort of the biological elements of it, the viruses, the bacteria, the protozoa, and other things. Obviously, there's a whole range of things that Tom talked about that we can do with respect to the chemistry, which Barbara will talk about. So I'm not going to steal that glory. But I still think there's need. People in public health surveillance are still, some of them are very traditionalists. They see wastewater-based epidemiology as being something new and therefore unproven in their eyes, and it's been difficult to convert some people to the path of WBE. And we'll only do that through generating evidence that actually influences policy, and that's the work that still needs to be done. So, but the future is essentially combining it with all of the other data sources, clinical data and infravalence, to provide better estimates of public health risk and influence decision making. And with that, I think I'm going to stop. Thanks, Tom.
Brilliant. Thanks, Davey. Super interesting, and yet some really world-leading stuff that's been going on in Wales over the last couple of years. So all kudos to you and your team who have been leading the charge on that. Next up, we have Professor Barbara Kasperczyk-Hordern, who is a professor in environmental and analytical chemistry at the University of Bath and is co-director of the Water Innovation and Research Centre. She leads the environmental chemistry and public health research group there as well, which currently focuses on the development of wastewater-based epidemiology tools for environmental and public health assessment. Barbara, over to you.
Thank you. Thank you, Tom. So the first 3 slides, we'll get through them very quickly because you have nicely introduced the concept of WBE. So yes, I'm going to talk about chemistry behind WBE. And what I'm going to say really nicely complements the discussion that the story that David has just told you about what he has been doing in Wales with his team. So yes, next slide, please. The focus of WBE is on people. So we tend to try to understand the health and lifestyle of people. And I think what we would like to achieve is to move away from people, only try to look at the wide environment. So Tom has nicely introduced us to the concept of WBE and One Health. And today I would like to link the two together. So we are part of the environment, and we also can, via our measurements, provide information not only about our public health, but also environmental health all together. So there is this cost benefit of doing so too. And next slide, also exactly this is what wastewater or water-based epidemiology could be about, because if we think about One Health, if we think about the wide environment, it's not only wastewater that we need to look at, we also focus on receiving environment, as well as solids and everything else that we could consider. So Tom has introduced you to One Health. I'm not going to say much about this, but I want to emphasize what WB can do if we want to utilize it in trying to answer some of the One Health questions. So one, WB can provide us with evidence on environmental public health status. But what is important, and Davey has already touched upon this, is that this data is not only for research purposes, it should be used to make decisions about an improvement of environmental public health. So WB can and should inform One Health actions, and not only do so, also evaluate mitigation strategies. And if we think about interventions or mitigation strategies, we think about policy making, we think about new technological innovations, as well as societal changes. And WB can do exactly that in terms of collecting information about effectiveness of various interventions. So again, there is this cost effectiveness in terms of thinking about, we are introducing new approaches in one place, a sentinel site. If they work, we can roll them out elsewhere. Next slide, please. So we in Bath are mainly chemists, so we focus on chemistry and try to analyze as many chemicals as we can. So you might not be able to read all the letters here, words, various different chemicals spanning from pharmaceuticals through to personal care products, illicit drugs, pesticides, industrial chemicals. And because we collect information via mass spectrometry data freezing approaches, we undertake retrospective mass spectrum mining. So we still actually work with samples that we collected in 2015 because we have this capacity, and there is this huge benefit of doing so, also from environmental point of view. So if there is a problem now, we can go back and mine the data and see where the problem started and why it started. So it's very beneficial. Next slide, please, Tom. Okay, so this is a kind of typical slide data they produce. But before I talk about pie charts that you can see here, I would like to tell you about the key catchment that we work with. It's the River Avon catchment in southwest England. It is about 362 kilometers squared, population of over 1 million. And we like working with this catchment because we know it very, very well. We work very closely with Wessex Water, so our local water utility, and we have access to data that Wessex Water collects for all the things. We just utilize the data sets. So what we tried to do here is, and we started building this in 2010, so we have several years worth data set for this catchment. We try to initially understand how communities impact our environment. So we focused on the major cities and towns in this catchment. So we have 5 treatment works that serve 5 cities and towns. So you have them as Town A, WTP, A, B, C, and D. But we also look at river water sites before and after, and these are the points S1, 2, 3, up to 8. So we did this study a while back. We're collecting samples all the time. We have longitudinal studies, 3 years worth for some sites. And we're trying to understand what happens in terms of spatial variability and temporal variability of various different chemicals. So, but what we try to do is not to focus on people only, and this is people equals wastewater. So this is the kind of top pie chart. So when we look at chemistry within wastewater, we see there's lots of chemicals that fall into lifestyle chemicals. We have lots of anti-inflammatories, antidiabetics are very common, mainly metformin, and many other chemicals. But then we also collect samples from receiving environments, so rivers, and we can get an understanding of how we, as well as agriculture and industry, affect our environment. And this is done in one sampling campaign, and I mentioned this cost benefit of doing this already. If I could have another slide, please. Thank you. And this is a kind of typical result. So in our study, one of many, we looked at over 200 chemicals, and we managed to collect all the information about the presence of chemicals in terms of daily loads. And then we managed to capture about 170 kilograms per day in wastewater. Out of this 170 kilograms, only 14 end up in the river. This is because of effective wastewater treatment process. But still, among those 14 kilograms, we have some really problematic chemicals, such as antibiotics. I mentioned here ciprofloxacin and some of the macrolides. And what we found out that they can exceed in wastewater, also in the River Avon, the PNEC values for typical environmental toxicity endpoints, as well as MICs, so inhibitory concentrations. And there is a worry, really, because we might be seeing issues related to antimicrobial resistance. But what was interesting here in the study that we've done, and these are the 2 graphs on the right-hand side, we have daily loads of various different groups of chemicals, antidiabetics, lifestyle chemicals, pharmaceuticals, illicit drugs, pesticides, industrial chemicals. You see that from city A up to CTD down, we see the increase in daily loads. And what we found out, that no matter where we are in the catchment, population normalized loads show very little variation in terms of what we discharge into the environment. And it is roughly 154 plus minus 12 milligrams per day per person. And this is an important piece of information, because if we know that community is the driver of the presence of various different chemicals in the catchment, we might introduce community focused interventions, such as, for example, educational campaigns. So what we started doing is trying to understand what kind of drivers there are in the catchment, and WB can provide us with a really amazing evidence approaches. So can I ask for another slide, please? So I'll give you one example on antibiotics and resistance genes. Davey already mentioned that there is a lot of work being done in Wales. This is our catchment work to start with. So we looked at various different antibiotics and the corresponding resistance genes, so sulfamethoxazole and SOL1 gene, chloramphenicol, CAT-A, macrolides, ERMB, fluoroquinolones, and QNRS. And what we tried to see, we did simple correlations. We try to understand whether there is correlation between the resistance gene and antibiotic daily loads, and also whether there is correlation with population size. So if you look at the 4 graphs, you see them in green, this antibiotics daily loads, and the bottom one resistance genes daily loads in 5 different towns and cities that we focused on. So what we could see that in city E, we have high levels of antibiotics, also high levels of resistance genes. And then second city, in terms of its size, 100,000 people, city C had second high level of antibiotics and second high level of resistance genes. And one might think this is due to the city size in terms of number of people contributing. And this is exactly what we see here. And we see it when we normalize daily loads to population. So population normalized daily loads, PNDLs. These are the graphs on the far right. We see then when we normalize population, we see daily loads loads of antibiotics plateauing. We still see little lower loads of antibiotics city A and B versus city C and D and E. Coincidentally, city A and B are in one particular region of Southwest, city C, D and E another region. There might be some issues when it comes down to prescribing in city C, D and E, so in the second region of the study. And again, if we have this understanding of the presence of antibiotic resistance genes, we might start thinking about an introduction of interventions. And here, an obvious one is reducing prescription, especially in city C, D and E. So something is happening in the region that requires us to look at. But yeah, in general, there's this notion that when there is more antibiotics, there is more resistance genes. Could I have next slide, please? And we were very curious about this. So what we have done, and I think that you need another click because there is one. Yes, thank you. So what we try to understand is that whether this is really the case. If there are more antibiotics, there are more resistance genes. So the idea is if we reduce antibiotics via some interventions, working with general practitioners, we might be able to reduce resistance genes levels. And in our longitudinal study that has taken well over a year to complete, we could see that actually antibiotics go up and down, and this is the blue and orange columns. So blue is the antibiotic, macrolides in this case, parent compound, and orange is the metabolites. We see that they go up and down depending on the season, more in wintertime, less in summertime. But resistance genes, and this is ERMB gene, the black dots, really does not follow the same patterns. And we were surprised to start with. We thought, okay, if we start reducing antibiotics, we might be able to see reduction in genes. Maybe we are too optimistic about how you can manipulate resistant genes in the environment. I think we're talking about totally different timescales, but this is for another research. So I'm not going to tell you more about today. If I could have another slide, please. Okay, so I mentioned earlier on that what we could see in our early studies that there is a clear correlation between the levels of various different chemicals and population size, but not all chemicals fall into this category. So what we did simple linear regression, we did some correlations, and you have here lots of different numbers, and you have also color coding. And I would like you to look at this color coding. So what we did, we grouped chemicals by the correlation with population size. So if there is a very good correlation of daily loads of various different chemicals, population size, we put them in green. So the greener the box there is the higher correlation with population size. So basically the presence of chemicals in wastewater is driven by our daily habits. So the more of us, the more of the chemicals in wastewater, and this is the group A. So you see it on the left hand side, and this high usage pharmaceuticals and lifestyle chemicals, anti-inflammatories, antidiabetics, antidepressants. So they're actually potentially very good markers of population size. But what is really interesting is to look at those chemicals that are red. So this means that there is something localized that happens in a catchment that makes people exposed to certain groups of chemicals, and we focused on those. And today I will give you one example of bisphenol A. If I could ask for another slide, please. So in the same catchment, we looked at bisphenol A. Bisphenol A is a plasticizer. It's banned in certain products, such as children's toys and bottles, but it is omnipresent. And we are exposed to bisphenol A mainly via food packaging, especially if we like microwaving food, still in kind of plastic wrapping. This is when we expose ourselves. And in general, the exposure to bisphenol A is considered to be below safety threshold levels set by Food Security Agency. We want to have a look whether this is really the case. So we looked at our 5 sites and 5 treatment works, and we looked at not at bisphenol A, we looked at bisphenol A sulfate, because as you can imagine, bisphenol A is everywhere. We needed to find a marker that is can be linked with internal exposure. So bisphenol A sulfate indicates, if we see it in wastewater, this means that it has gone through our bodies. So we excrete it with urine. So on the right-hand side, you see 5 different graphs for city A, B, C, and D. And we have bisphenol A sulfate loads, milligrams per day per 1,000 people. And you see in city A, C, and D, there are very low levels of bisphenol A sulfate. These are coincidentally cities that with wastewater that comes only from residential communities. There is no industry there. While city B and E, these are the most industrialized cities in the catchment. And they have around 30% of industrial waste water coming from, again, coincidentally, food packaging industry, paint formulation industry. So there is a lot of bisphenol A there. But what we could see, so these are cities B and E, what we could see that there are high levels of bisphenol A during weekday versus weekend. So in the pink column indicates weekend. And we start thinking, well, something is happening in these 2 catchments, and it must be occupational exposure because we have these high levels during weekday, lower during weekend. So again, Wastewater Based Epidemiology can provide us with another information about another driver. So this is the occupational exposure. Could I have another slide, please? We also looked at many other chemicals. So one of them, interesting, and the group of chemicals is linked with pyrethroid pesticide intake. Here we looked at 3-phenoxybenzoic acid, it's called 3-PBA, and we also looked at triclosan sulfate. You see, we are looking at metabolic products of parent compounds that we are interested in. So what we could see that this is city E, pyrethroid pesticide intake, 3-PBA load, goes up during weekend. And again, our thinking is it might be because we maybe want to eat more vegetables. As a result, we expose ourselves to pyrethroid pesticides in this way, or maybe we do a little bit more gardening during weekend. That's why our exposure is higher. But again, WB can provide us with this information. Interestingly, triclosan was the same throughout the week, so there was no weekday versus weekend variability. Could I have another slide, please? And linking with the environmental health dimension, because I wanted to provide you with this linkage. So when we do our work, we also look at parent compounds that I mentioned in metabolites, and we try to understand whether all the chemical markers are linked with internal exposure, and whether they they are present in wastewater because of other means. And what we managed to see on a regular basis is direct disposal, dumping down the drain of pharmaceuticals. We should not be doing this. And obviously we do, because we see, and one example here is carbamazepine. One particular day, it's Sunday, you see the top middle graph with black column, higher levels of carbamazepine. If you look at the bottom graph with the green, carbamazepine 10-11 epoxide metabolite, carbamazepine 10-11 epoxide is stable throughout the week. Carbamazepine, the parent compound, shoots up on Sunday. This is the case of direct disposal, and we see it all the time. Here, someone dumped down the drain 253 pills on Sunday. It's a lot, and it's a lot that this can cause acute intoxication of aquatic organisms living in the receiving environment. Something that is not necessarily captured via usual monitoring campaigns, but it has a genuine detrimental effect on aquatic life. And again, we can back calculate this via WB tools. And again, if we know that, we can introduce intervention strategies, and this is what we are doing locally with our local authorities and with Wessex Water, as well as with NHS. Try to understand where we can educate citizens so they don't dump pharmaceuticals down the drain. Could I have another slide, please? And yes, we have done a lot of work during SARS-CoV-2 pandemics. I'll be very brief. I think I need to finish very, very soon. We looked at hundreds of different markers and tried to see how pandemics changed our habits in terms of consumption of various different pharmaceuticals. So pandemics was the driver of the change. And just a few quick examples. Paracetamol is the top left graph. At bottom is ibuprofen, its metabolite. So the kind of orange, blue boxes are pharmaceuticals themselves, and the gray lines, this is SARS-CoV-2, and yellow boxes indicate lockdowns in England, in the UK. So what we could see that the consumption of paracetamol went up, correlated very nicely with SARS-CoV-2 cases in the catchment, similar, although not as apparent in the case of ibuprofen. But when we look on the right-hand side, we see that atenolol benzafibrate, these are pharmaceuticals used in cardiovascular disease treatment, they were the same throughout the monitoring period of 2 years. Much more very interesting information we have on this, but we are still working with the data. Could I have another slide, please? So yeah, very briefly, I need to be very quick. We have worked together with Bangor University, Davies team, and UK Health Security Agency in trying to do the same, but combining forces in terms of biology and chemistry in England. So across the whole country, it was during SARS-CoV-2 pandemics. So we targeted many different chemical and biological agents. We are still crunching the data, but some really, really interesting things are coming out. If I could have another slide, because I know I need to finish. So this is one example of correlation. This is correlation coefficient to determine the relationship between population normalized daily loads of various different BCIs. These are biochemical indicators. So you can see a lot of red, a lot of green, a lot of yellow, and just very quick comments here. So we could see, for example, that norovirus, SARS-CoV-2 correlated with antibiotics. We don't want to see this correlation, because if we see this correlation, it means antibiotics are not prescribed in the way they should. We could see correlation between nicotine and cotinid's metabolite of nicotine levels, with cardiovascular pain, antihistamines, and antidiabetic drugs. Interestingly, we also could see correlation between metformin and nicotine usage. And we know that those that smoke and those that have diabetes will need to take more metformin. So we see this in wastewater. We see very nice correlation between metabolites and parent compounds. This is what we would expect. And also certain cardiovascular chemicals, pharmaceuticals correlate with each other. Much, much more I could talk about, but just wanted to give you a snapshot of what we are working on at the moment. And I think next slide is my last slide, just to emphasize the way forward is for microbiologists and chemists working together, also with engineers, and trying to build a bigger picture, to provide a tool that is fit for purpose for decision makers. So biology and chemistry need to go together, and we have some first a snapshot of the results that we have managed to produce during pandemics, and we are working on as we speak on the well samples. I cannot provide any results at the moment. And final slide is just to say thank you to everyone who contributed to this work, our amazing environmental chemistry and public health research group in Bath, as well as various different funders. And I always emphasize Wessex Water's contribution, so it's our local water utility. Without the support and provision of data and results, we would not be able to achieve what we have managed to do. Thank you.
Fantastic. Thanks, Barbara. Again, another really insightful talk. I think great to see the breadth and depth of knowledge, expertise, collaboration happening in this space. Yeah, clearly some massive potential in terms of applications, both for the water industry and the wider sector. Great stuff, really. I think that wraps sort of up our main talk. We have a bit of time left now for questions. I've not got sight of the chat at the moment, but I can, while I bring it up, are you okay to relay any questions that may have came up on there so far? And in between us, we can have a go at answering them as best we can.
Sure. Thank you to both of the speakers for the talks as well. And I see that Davy has started to answer some of the questions in the chat, so I'll just go to the ones that haven't been answered yet. There's a question here for Barbara. Have the public authorities got a plan for drug dumping, given your evidence?
So yes, there is an interest in doing something about this. It's a challenging one. So we work locally with local government and with Wessex Water. So water utilities have interest in this too, because obviously they're responsible for our waterways. As far as regulation is concerned, I think we are not there yet, but there is genuine interest in looking at non-technological ways in terms of solving the problem. So we are thinking about education. We are thinking about also social prescribing in terms of removing pharmaceutical levels in our rivers. So this is happening. Whether regulation is going to be in place, I don't know, but there is an interest in terms of local authorities as well as Environment Agency and DEFRAN in trying to take some of the ideas forward.
Okay, thank you. And we have a question as well for Tom. How does ARIP, if we use this data, and what kind of projects do you see this being used for in the future in conjunction with the speakers?
I don't think operationally we use this data in its current format a lot in terms of the infectious diseases, but in terms of how it could be used, I think there's a big opportunity area around kind of more informed and new approaches to health-led infrastructure, the way we design places and spaces, and essentially kind of using data around kind of wider societal determinants of health to reduce health inequalities in cities and the likes. We did recently publish a paper on kind of future use cases with Barbara and Davy around some of those, potential ways that it could be used depending on what you monitor for in wastewater. I think in the actual water sector, I think there's big opportunities around using WBE infrastructure to actually optimize assets. So things like treatment works, better understanding of what is going in and coming out of treatment works, a better understanding of things like emerging contaminants, like Barbara mentions, to optimize those processes, and a better understanding of kind of what's going in and out to address things like combined sewer overflows and discharges. So yeah, lots of areas of opportunity. I think it all comes down to what's the kind of strongest case for things to monitor. Hopefully that answers the question.
Sure, thank you. And then I believe there was one other question for Davy. Do you have a view on where the science could go next, especially in a connected world?
Yeah, I mean, that's a great question. The Gates Foundation look as though they're funding, the support of the use of WBE at all the major transport hubs around the world to look at the global connection of disease-causing organisms and how they travel around as a sort of a smart surveillance system. I think at the moment we still are largely in centralized lab facilities. I think there's a lot of mileage in the development of what I would call semi-quantitative portable devices that allow you to do WBE in remote settings. I think that's an area for huge potential, particularly linking these sort of sensors up to smartphones where you can almost report to the cloud in real time as well. Certainly for bathing water qualities, wild swimming, as it's now known, I think it was just called swimming in my day, but wild swimming is one of those things that lots of people get sick from wild swimming, which is swimming in the ocean or the river. But in theory, people can do their own self-testing going forward. So WBE, I think, will always have centralized lab facilities because of the quality assurance and quality control that's required to do the type of high precision analysis. However, I think there will be almost like personal health testing. There'll be personal environmental testing for when you want to evaluate risk.
Okay, thank you. At the moment, I don't see any other questions in the chat, although there are requests for links for published works from both of the projects, if we can facilitate that.
Fabulous. Thanks, Emma.
Is there another way of sharing our work, or it's just we just need to now use chat and provide some links? We'll be able to do it later on. No.
It's a good question, one which I don't know the answer to. I hopefully we'll be able to get a list of people that have attended this call, and then we'll be able to distribute papers and the likes and research to everyone on this call if that's possible.
Sounds good.
Brilliant.
Sorry, looks like we have one more question reposted. I believe it's been answered a little bit, but if you'd like to expand, Davey, on what the challenges with data ownership and privacy is with these studies, or Barbara, if you'd also like to contribute to that as well.
I'll kick off and then Barbara can fill in.
Yeah.
With respect to because we sample small communities, 400 odd people, that's deemed to be still not compromising ethics. Obviously, where you've got thousands of people, you can't identify any of our data back to individuals. I think there does come an issue where you use WBE for detecting criminals or terrorists, for example, where you're picking up human DNA. That is a different ball game completely. It's completely possible to do that. There, obviously the ethics become very stony ground. But I think for the sort of community surveillance we do, we've never had any problems with ethics. People are super supportive of this type of work in comparison to being individually tested, which they don't want. They'd much rather have this. So that's a win-win. And generally, in terms of data availability, all of our data, because it's owned by Welsh Government, is available on a Freedom of Information request, but is available anyway to people if they want it. So, Barbara, I don't know whether you want to pick up on yours.
Yeah, just to learn. We started with illicit drugs years ago, and obviously there were concerns, not in terms of identification of individuals because we can't do this. It's a pooled sample. But stigmatization of various, for example, regions of the city, so certain communities. So we from the very beginning were very strict in terms of how samples are collected and how small the population size can be to actually monitor for illicit drugs. So I think it depends on what we are looking for, and the next step needs to be to draft the processes and protocols that need to be applied in terms of taking things forward. But yeah, as Davey said, when it comes to the public health dimension, there is, and we are collecting samples from many individuals, especially when we work at the waste treatment plant level, there is no issue with the identification of individuals. But yes, we need to make sure that when we go sub-catchment to individual buildings, for example, then ethical concerns need to be considered.
Thanks, Barbara. On that, I think we've got 1 minute left to just wrap up. Very good session. Thanks everyone for attending. Yeah, great talks. Clearly a massive area of opportunity in terms of how wastewater monitoring can be used as you say, David, probably part of a suite of One Health surveillance tools. Probably no more important time than now to kind of move the conversation forward beyond just using it for COVID-19 and infectious diseases. So yeah, really encouraging stuff. I'd just like to close by thanking our speakers, Davy and Barbara. Thank you very much for your time, particularly as Barbara is currently on holiday. Thank you for leading the charge in terms of the research and innovation that's happening in this space. Thank you all for attending the session. I hope you found it insightful and that it sparks some follow-up conversations and discussions this week. And for those of you in Stockholm, enjoy the rest of your week. For those attending online, enjoy the rest of the programme. And bye for now.